Here we have Michael. He's the numbing lead for oral surgery, right?
Yeah.
Which we are going to have one main numbing station, but we want to hear all your wisdom on all things numbing.
Well, first of all, I like the idea of one numbing station. I think it's nice because the problem that we have is that sometimes we lose some of the people to go on breaks, and so we're having to steal some people from hygiene to come over, or steal someone from the other station, or they shuttle people from our section over to their station and back. So it's a little inefficient in that aspect, but you know, it is nice to have the little breakdown because we do have a lot of the general dentists that are working in our numbing station, so that when oral surgeons or the dentists who are doing extractions leave for lunch, or if it's a turnover of a group, then we can take some of our anesthetists and bring them back to do extraction. So that works in that sense, kind of splitting them up to do that. But the one thing that we found that that drives the surgeons crazy is when the patients come back and they're not numb. So a little protocol that we have for doing blocks on the lower is we'll do a double block. We'll do your normal IA lingual and then aim high. You know, the oral surgeons will block with septo. A lot of the general dentists that we have don't want to do that, so I say if you feel comfortable blocking with septo, you can do that. If not, go ahead and go with Lido. And then we always infiltrate with septo first, and then follow it up with Marcaine. We always keep a little bit of 3% plain sit nest just in case the patients can't have epi. But in that case, we usually wait to numb them right when they get in the chair with the oral surgeon. So just keeping a good stock on hand. You know, we kind of separate things out. Setting up the trays beforehand sometimes can a little bit backfire if you're putting too much anesthetic, because sometimes, you know, they're not using the lidocaine, they're maybe just using Marcaine and Septicaine, or maybe they're just doing maxillary infiltration so they don't need the long needle. So it can be somewhat inefficient having them out. So what we found works better is just having the bib, mirror, syringe, and the little bib ties in the tray, and then always a short needle, and then you can leave extra long needles out on the table, whatever carbs of anesthetic they want. But preloading them up, usually that happens in a lot of other areas. When they preload and make things, you end up saying, oh, well, we don't want this for that, or we don't want that for that. So they're taking apart and picking apart, so it's a lot of...
Is there more waste?
Kind of a wasted time too, yeah. Waste of time and then waste of materials. So we ran out of cotton tip applicators today, so we had to take apart some of the things that were pre-made.
So who makes the call on when to get somebody numb, or who keeps an eye on that? Is that the lead's job?
Yeah, so when we're bringing them through to the area, we you can see over there, that's how we have our waiting area, and there's two different sections there. So they'll go in, they'll check in over at the orange table there, and then patients will be assigned based on their routing number, not their patient number. So patient number is when they came in the door, routing number is when they were given the slip for extraction. So we try to stay true to the routing number and keep them in somewhat of an order and snake them around the chairs. When the person is ready to be, or the next number is ready for a patient to come in, hold up their green card, patient will come back into the chair, and then they'll review health history and then what teeth are going to be pulled. A lot of times there is a little bit of a discrepancy of trying to figure out what should be done based on the triage. So we look at the sheets, and then most times they'll end up either coming to myself or the oral surgery lead and asking, say, hey, you know, first priority was upper right quadrant of extractions, but they have a lower arch full of root tips, and it looks like it would take about 15 minutes to get them all out. So we say, yeah, go ahead and do that. So it's a judgment call, and I think, talking with you earlier, it's definitely comes down to triaging things properly and having that, if time is allotted, then do the rest of the work. So that works for us.
As far as timing, like I assume you have a waiting area in the actual extraction area, and then you're looking at those chairs, and when they start getting empty, then you start numbing, or?
Yeah, so we have the waiting room outside, then we bring them into the numbing area where we had actually 9 chairs. We brought an extra one in, set up in there. Once they're done getting numbed, the number or the anesthetist raves their card for one of the escorts to take the patient and transfer them from the chair over to another waiting area that we have inside of our room And then when there's chairs available inside extraction, that's the on deck. So they're kind of in the hole when they're our area, and on deck once they get into the oral surgery waiting area. So there's really 3 separate waiting areas within each, you know, with all the different components that we have for outside, numbing, and extraction. So, and then there's just a system of cards to indicate when people are ready, when they need to be moved, or if they need instruments. So I'm sure you have some sort of system like that in place for
Well, we don't yet,
communicating. But no, yeah, the card system works good.
Okay.
I mean, you can see them right here. So you know, it's the new patient. So they need a technician, EMT, X-ray, and then patient exit and translators. Yeah, different languages. So
very good.
Yeah.
All right. Well, happy birthday and thank you very much.
Thank you.